And welcome to another edition of 50 Shades and Grey, where I am joined today by Dr. Philippa Kaye, who is a celebrated author. She's got 9 books. To me, that's a library. 9 books. She's the GP to This Morning, so you will recognise her from that. And her latest book that we're going to talk about today is The Science of Menopause. So it's a subject that we've dealt with recently on the podcast. So we're going to get an expert's opinion on that and get her to talk about a new book. So thank you for joining the show. Thank you very much.
Thanks for having me.
Shall I address you as Dr. Kaye? Is that okay with you?
You can call me Philippa, it's fine.
Philippa, this is my one and only GP joke. This is the quickest that I've ever got an appointment with a GP in the last couple of years.
Well.
So thank you for joining us. Your new book, congratulations on your new book. When is it due out? Tell us all about it.
So this is the new book, Science of Menopause, published by Dorling Kindersley. It is out from Thursday, the 10th of October in the UK and the US, and then it will keep going round. And I'm incredibly, incredibly proud of it because it does exactly what it says on the tin here, and it explains the basic science, but also it gives the most up-to-date evidence-based guidelines. And I think that when we are in the world that we're in, where social media and the internet has taught us so much and it's connected us in so many ways, there's also an awful lot of misinformation out there. And you need to go to a trusted, reliable source to know that what you're hearing is correct. But also, I've written a menopause book before, but this is very different. 1, because it has a global perspective, but 2, because it is absolutely jam-packed full of illustrations and infographics. Not everybody likes to read an essay-type book. I'm talking to a teacher here, right? And a picture paints 1,000 words. And so for people that learn in different ways, there are loads and loads of pictures and illustrations and graphs and things like that to help people really understand. Because for me, education is empowering, and that's the only way that we're going to help change the narrative and the stigma and silence around the menopause, and that is by learning about it.
I think that's exactly right. I mean, as I said to you before we came onto the podcast, my knowledge of it is 200 times more than it was a few weeks ago, and it's still very little because obviously as a male, and having not been totally honest in a long relationship for a long time, I haven't been around it either. So my experience of it has been through friends, through male friends and through my female friends, and listening to them, and also at work listening to the sort of the teachers that I work with at work. When you said this is different from your last book because there's more of a global perspective on it. So can you explain that?
So the menopause means the last period, and it's what we call a diagnosis of retrospect, and that means that it's a diagnosis we have when we look back, when you haven't had a bleed for 12 months, a period bleed, unless we take your ovaries out, and that's a different scenario. And the average age for the menopause is often quoted as 51. But actually, that's the average age for Caucasian, North European American women. And we now know, there was a huge study in America that showed that Black American women and Black Latina women, actually the average age of menopause was 9 months younger. And when you look globally, the average age of the menopause is significantly younger, with India, the average age being about 46. And yet what we don't know is what would happen if you picked all the women up, let's say from India, and moved them into a Western society with access to food and Western medicine, etc., what might happen in that scenario. So there is a lot of information that we simply don't have. But I really tried here to put in what we do know. So there was a huge study called the SWAN study in America, and it showed really clearly actually that Black women might be more common to have one kind of symptom over another, or Latino women to have one symptom over another. For example, Asian women commonly present with aches and pains more commonly than hot flushes, and hot flushes are the commonest, what we think are the commonest, the most famous symptom of the menopause. And so actually things like ethnicity are and do have an impact on the menopause. And this for me is really ties in with what I find so interesting about women's health, which is that women's health is so closely bound up with women's place in society and culture and history and religion and, right? And now we're saying, and now let's put ethnicity into the mix. And it's complicated. And that's what makes it fascinating to me. And so I really wanted to ensure that no group of women was left behind in this group. And so in this book. And so that might be talking about issues about ethnicity, but it also might be, for example, talking about menopause if you've had cancer, menopause if you can't have HRT, menopause if you don't want HRT, right? And I feel that there is a long way to go in terms of the menopause space. And women's health has been chronically underfunded for a very long period of time. And the only way that we are going to make change is if we're all in this together. So we can't leave groups of women behind, and we definitely can't leave the men behind either, because it's only when we're all acting together that we're going to affect real change. And whilst I say that I am a GP who has a particular interest in women, kids and sexual health, I also don't really believe that there should be such a thing as women's health. I think it's just health.
Yeah.
And that we all need to know about each other's health all the time, right? Because 50% of the population are female. Actually, it's just over 50% of the population are female. And that means that everybody's got a mum, a sister, a partner, a work colleague, a friend, a someone that might be going through the menopause. And we all need to know about it. And in the same way that often when people come into my surgery and they say, I found a breast lump, and I say, how long have you had it there? And they say, well, my partner found it. Or a man comes in and they say, I've had whatever symptom they've had. And I say, how long have you had it? And they turn to their spouse and they say, how long have I been moaning about it? And we live together. We work together. And so actually we all need to know about each other in order to help each other.
I've noticed, like I say, from my experience, the effect that it actually has on relationships as well, without the understanding. And I think I'm very naive, like I've already said, and I think men's understanding of the menopause has been very minimal, really, and understanding how to also to deal with their partners that are going through it, because it's I would imagine a very frustrating time for both parties to sort of explain what's going on, how they're feeling. And as a guy, you can maybe empathize with it, but it's very difficult to understand it because you're not going through it. So, you know, what
Absolutely.
can,
And it's not
what,
that's not the fault of men.
no,
That's the fault of society and what it's been considered appropriate to teach men, right? And so menopause has been included in the PHSE curriculum in secondary school for a little while now, but it's not necessarily taught to everybody. And even if we did teach it to everybody, okay, great, that means that the 16-year-olds know about it, but nobody else does yet. And so we definitely have a long way to go. And when I go into schools and I deliver talks, and I do part of the PHSE curriculum, I always say I want to talk to everybody together. It's important that you have an opportunity to speak separately, but actually, there's no reason why the boys shouldn't be hearing about the periods and why the girls shouldn't be hearing about whatever it is, ejaculation, whatever it might be. And we do everybody needs to examine their chest, breasts. Let's talk about that together. And it's only when we do that, one, that we help each other, but two, that we stop some of those harmful jibes and jests and jokes that are really actually quite damaging. The sort of you on the blob bit, right?
yeah.
It's all slightly derogatory, it's all slightly putting down and slightly sort of minimizing. But actually, if men understood what was going on, then whilst they won't be able to have an experience of it themselves, they might be more sympathetic. And I think that we are really kind to teenagers, right? And we explain away their moods and their need for sleep and all this stuff. And we say it's hormones and their brains are developing, etc., etc. We aren't kind to women in midlife. Women aren't kind to women in midlife. And we all need a better understanding.
That brings you quite nicely on to one of the questions that I had, because you say about the education through schools now. And I was wondering today if you are finding that younger women are now sort of asking more questions and saying, so, when is this going to happen to me? Because, there's as a woman, I imagine that there's a lot that goes on. So are you finding the age of women now sort of looking forwards to sort of asking questions, saying, when am I going to experience this? What am I looking for? And what can I do? And is there anything you can do that helps prevent it or delay it or cope with it moving forward?
So first of all, not enough. Not enough women are thinking about this early on, but also not enough doctors are. So as I said, average age for the menopause 51, but just starting your period was one moment in puberty, and puberty took you a period of years. So too, the last period is a moment in time, but the perimenopause, the lead up to that, you can have periods and you can have hormone levels which are fluctuating, and that can cause symptoms, and it can take a period of years. 1 in 20 women will go through an early menopause under the age of 45, 1 in 100 under the age of 40, 1 in 1,000 under the age of 30, 1 in 10,000 under the age of 20. So if 1 in 1,000 women under the age of 30 are going through it, and they might have symptoms 8-10 years before that, both those women and their doctors need to be considering it. And some of those symptoms are vague and can have lots of other reasons, like fatigue and loss of libido and insomnia and low mood. Those can have lots of different reasons. And so the numbers that I gave you are probably actually lower than they really are, just because neither women nor their doctors are thinking about it early enough. As to what you can do to prevent it, you sort of can't. But there are some things that you might be doing that might make it earlier. So you are born with all the eggs you are ever going to have. And actually, the egg that you came from was formed in your mother's womb while she was still in your grandmother, which to me is unbelievable.
Yeah.
They were formed, the egg which you came from was formed in your grandmother's womb. But anyway, and so you are born with all these very immature eggs, and you lose loads of them actually before you get to puberty. And although only 1 or 2 eggs are produced each month during ovulation as part of the menstrual cycle, you lose actually about 1,000 eggs each month. And when you run out of eggs, the menstrual cycle will stop, and you will go through the menopause. And the way that it works is that you will produce the best quality eggs when you're younger, and then sort of things might get spaced apart. Now, so how many eggs you had was sort of set before we did anything, before you were even born. But we do know that women who smoke go through the menopause 2 years earlier on average than those that don't. And that might be due to how smoking affects the blood vessels and the blood supply to the ovaries. We know that if you have your womb removed, even if you leave the ovaries in, that you're likely to go through the menopause a couple of years earlier. And again, that might be due to changes in blood supply. We know that when women have a premature menopause, often that runs in families. And so that there might be some kind of genetic component. It might be related to autoimmune conditions where the body's immune system seems to attack itself incorrectly. But actually, a lot of a premature menopause is due to medicine or surgery. So, for example, if your ovaries were removed due to cancer, if you had chemotherapy, for example, or something else that affected your ovaries. We need to be thinking about it earlier than we are. And I say this as somebody that had cancer and chemotherapy at 39, and they put chemotherapy bars directly into my abdomen and pelvis, and yet nobody mentioned the premature menopause once. They asked me once, before I started, they asked me if I wanted to have any more babies, and I said, thanks, I've got 3. And then it was never mentioned, right? And I'm a doctor, and still it wasn't mentioned. And so we, in a situation where we almost knew that it was going to happen because of that chemotherapy, and still it wasn't mentioned. So we definitely have got to do more about this space. But younger women can do that. What we do as young women impacts our health later in life. So ensuring that you do weight-bearing exercise and muscle strengthening exercise, ensuring that you have the best bone mass before you hit the menopause, that kind of thing is really helpful later in life.
One of the things that you said there, so for a woman starting to experience these sort of symptoms of a menopause, if her first stop would be, I would imagine, would be the GP. She would go to the GP. Is there a sort of, like you said, there's not enough awareness of it with the GPs? Is that something that's changing in their training now to sort of for them to learn more about, or is that usually off the own GP's back if they've got an interest in it in the first place?
So, first of all, GPs are specialists in general practice, which means that we need to know a little about an awful lot. And often people sort of belittle GPs, and I think that GPs have a very different job to a hospital doctor. My job is to rule stuff out. By the time I send you into hospital, the hospital doctor already has had a doctor say there is something here, even if I don't know what it is. And a hospital doctor's job is to rule stuff in. And that's a slightly different way about thinking about things. Menopause, you can be a GP and not had any menopause training at all. That is true. And there are lots of things that are changing about that. But you could have got to general practice and not had to prescribe the contraceptive pill before. And contraception is bread and butter of general practice. And I think that we are moving quickly, actually, towards menopause care being part of the bread and butter of general practice, because it should be, because it's going to affect every single one of your female patients at some point. But if you are over the age of 45 and you have classical symptoms related to the perimenopause, so changing to your periods, they might be actually getting heavier as opposed to lighter, might be getting more frequent, hot flushes, sweats, headaches, joint pains, loss of libido, insomnia, fatigue, anxiety, depression, worsening PMS, etc., etc., etc. If you're over the age of 45, you do not need blood tests. So for all those places online that are saying, come have perimenopause blood tests, come pay privately, you do not need them. And that is because 1 month in the perimenopause, you might ovulate, and the next month you might not. So the hormone levels are going to be going up and down. So those blood tests are meaningless. And therefore, they're just taking your money. If you are over the age of 45, it is not recommended to use blood tests. We will go by symptoms alone, and we can still treat you whether or not you're having periods. If you're under the age of 45 and you have those symptoms, I will do blood tests because I want to rule out other things. So, for example, if you have low thyroid hormone, if you have too much thyroid hormone, you can have symptoms of the menopause and your periods might go up the spout. And HRT is not going to solve that, or exercise is not going to solve that, because what you need is to treat the thyroid issue. So if you are under the age of 45, we will do blood tests, and definitely under the age of 40. That doesn't mean that the answer isn't that you're going through a premature menopause, but we would need to rule out other things before we got there. And even if we did check the brain hormones, which we would expect to be higher after the menopause in a young person, we would need to repeat that 6 weeks later to ensure that it wasn't just a random one-off blip. So I think that the first thing that young women need to do is when their symptoms are bothering them, it's time to go and bother the doctor about it. Yes, we need to talk about it, but it isn't the only cause of things. And right now, it can feel like if you're a woman over the age of 45, whatever your symptom is, you're told it's related to the perimenopause. And that's not necessarily true.
I think that's one of the other things that I was about to come to. And I think we find this with most things. When there starts to become more of a spotlight on a subject, there's all of a sudden, it seems to be loads of information that comes out about it. And one of the questions from speaking to women, or the feeling of them, is that at the moment there is so much out there, but it does seem to be people trying to sort of cash in on sort of menopause. Is there a lot of misinformation, like you say, with the blood tests out there? And is that the case with a lot of the information, a lot of these sort of like fitness regimes that are saying, right, you need to pay £30 a month and we'll tell you how to sort of help this and help that? Are you finding that, or have you seen that?
So meno washing is a real issue, that I don't need a supermarket aisle with a big pink M on it. We do not have any data for menopause chocolate helping your symptoms, costing probably around £5 a bar. Menopause pajamas made of cotton to wick away sweat are the same as cotton pajamas, they just cost more. Menopause face cream, there isn't an active ingredient in menopause face cream in comparison to other face cream. And when we are struggling, when we don't feel our best, we are vulnerable and we want to feel better. And so when somebody says, pay this, take this supplement, take that supplement. I mean, my DMs are full of people wanting me to advertise supplements that I don't advertise every day. Try this, it will be marvelous. And actually, we don't have the evidence for that. And I think that where we don't have evidence, it's really important to own that and say, we just don't know yet. And when there is a void, and as I said, because we don't have enough research, when there is a void, misinformation fills the void. People don't like a void. And there is an awful lot of science out there, but not all of the science is good. And so my first thing that I always say is, when someone's trying to sell you something, be wary. Because I could cherry pick bits of data to tell you all kinds of things, but that doesn't mean that the method of the study was good. And it doesn't mean that I tell you that the study had 3 people in it versus 300,000 people in it, and various other things. So if someone's trying to sell you something that isn't just information, then I would always be slightly wary. And I think that's why, that's one of the reasons why I wrote The Science of Menopause, which is based on the guidelines, and it's based on the British Menopause Society guidelines and the NICE guidelines and the North American Menopause Society guidelines and the International Menopause Society guidelines, right? So that women would be able to say, Dorling Kindersley, they go and get the truth, that's my publisher, and I've gone to somebody that knows. And there are so many pages of references. I feel very sorry for the person that had to type up all those references in this book. And that you can then take that to your doctor and say, I've read this is what I think is going on. Please, can you advise yes or no? And people are often worried when they come to me and they've ripped something out of the newspaper, and I never worry about that, because it just shows that we're on the same side, and that side is to do what's best for your health. And if I look at it and I say, actually, I've read this study, there's a flaw in this, or I agree with it, let's talk about it. If I've never read it, or don't know about it, I'll go away and find that out for you. Don't ever worry about a doctor that says, I don't know, let me find out and contact you. That's a doctor knowing the limits of their knowledge and trying to expand that for you. And then I would say to women, it's really important that if you disagree with your doctor, that you ask them why. And I think that my job is 2 things. I have to know some stuff about stuff. I have to be nice to you and communicate that to you. And if I know the stuff about the stuff, and yet you haven't understood why we've made a decision, then I haven't done my job properly. So if you say to me, well, why can't I have HRT? And the answer is, I don't know, because you're allergic to it, whatever, then you can understand that. If the answer is, because I don't believe in it, well, that's not a reasonable answer, is it? And you would then challenge that. And I think that, so getting empowered, taking something like a book or printing out the guidelines is really useful. I know that a lot of women, and this is coming out soon, so I know a lot of women will have watched a recent BBC Panorama, and that talked about various things, including the supplement industry, saying that there wasn't evidence for a lot of these supplements. And it focused on extra super high doses of estrogen in HRT. And it has been now just over a week, and my clinics have been full of women terrified about their HRT. It's really important that we don't go backwards here. HRT was really widely prescribed in the 90s and the very, very early 2000s, and then numbers plummeted after the Women's Health Initiative trial, which showed that HRT seemed to increase the risk of breast cancer. And we have very good data now. What we know now is what was given in that trial is not the same as what we give now. The average age of a woman in that trial was 63, so over 10 years after the menopause. And it seems that there's a window of opportunity when it comes to HRT, that if you give HRT within the first 10 years of the menopause, that the risks aren't the same as when the body has got used to not having that estrogen and then is suddenly shocked with it again. And it used old-fashioned oral estrogen and various other things that we don't do now. And so we talk about the risks and how we can modulate those risks. So, for example, if I give you estrogen through the skin instead of orally, I don't increase your blood clot risk. And every single person needs to weigh up their own risks and benefits. The small, very small, but is there, very small increased risk of breast cancer versus symptom control versus decreasing your risk of osteoporosis, of decreasing your risk of bowel cancer, of keeping your job. not having to, give up your work, maintaining your relationships, all of those things are really important. But in that panorama, they were talking about using extra high doses of estrogen way off the license. And the truth is that we do not know how much progesterone is needed to protect the womb in that situation. We do not know that that is safe. We have really good data about the doses which are licensed for. And so I don't want anybody who is on HRT to suddenly stop taking it, because you probably wouldn't feel very well. And I would never recommend that anybody on any prescribed medication suddenly stops taking it without talking to your doctor. And even if it comes out that you were prescribed a super high dose, then your doctor together and you would decide how we dealt with that. There's always exceptions to every rule in medicine. And sometimes in a premature menopause, you will need higher doses than after the menopause. But I think that it's really in this past week, and I've done so many interviews, and lots of people are almost scared to bring up HRT, and they're only asking me questions about lifestyle, or they're only asking me questions about herbs. HRT is an important part of the puzzle here, and it is very effective. And for the vast majority of women who can take it, who is not contraindicated in, for most of them, the huge benefits will outweigh the small risks. So I really don't want people who watch that to be afraid of HRT. Every single person needs to know two things. One, it's not lifestyle or medicine. It's always lifestyle and medicine. It doesn't matter if I'm talking about high blood pressure or HRT, whatever it is, it's always lifestyle and medicine. But two, that HRT is an important part of the puzzle for many people, and that for many people it is safe. If you can't take it, let's say that you've had breast cancer, if you don't want to take it, you just don't want it. We have loads of other options. We have lots of non-hormonal prescribable alternatives to HRT. Some of those are antidepressants and anti-seizure medicines, and that doesn't mean that I think that you are depressed or have epilepsy. Those are medicines that we use to treat other things. I would use an anti-seizure medicine to treat migraine, to prevent migraines coming, to treat nerve pain, to treat all kinds of things that aren't epilepsy. So it doesn't mean that your doctor suddenly has decided something else, but they should have explained that to you in an ideal world. We have new medicines which work on how a hot flush is caused. We also know really clearly that cognitive behavioural therapy, talking therapy, works for physical symptoms of the menopause as well as psychological symptoms. We have options, and I think the most important message is that if it bothers you, it's time to bother me. And even if you think I don't want X, Y, or Z, still come and talk to me, because there are so many things that we can do.
I'm so glad you brought up the Panorama program, because like I say, I think that's a conversation that I've heard with women I know at my work that they've been talking about. And it has, as it does with headlines, it is quite a lot of scaremongering sometimes, because they need to be dramatic headlines to grab people's attention. From what you were saying there, is menopause can it be a very individual thing as well in terms of how it's treated? Because I hear women sharing information, especially when you say about HRT, saying you need your doctor to get you on HRT. So is that something that will work great for one person, but maybe not for another woman? Or is it sort of a standard practice for most people?
I wish medicine were as simple as take medicine X for condition Y and you'll be fine. I also wish that patients would sometimes present like the textbook, because I learnt those textbooks. And, but people are more complicated than that. We know, for example, actually really clearly that about 1 in 4, 1 in 5 women won't have any symptoms of the menopause at all, will have very mild symptoms. That about half will have moderate symptoms, and the final quarter will have very severe symptoms that impact on the quality of their lives, to the extent that 1 in 10 will have thoughts of suicide. We also know that for the quarter of women that don't have very many symptoms, they're fine, but about a quarter of the women will have symptoms for up to 10 years before that final period. But actually, those symptoms improve pretty rapidly within a couple of years after. A quarter of women will have symptoms that spike around that last period, so 2 or 3 years before, 2 or 3 years after. And the last quarter of women won't have symptoms until just before that last period, and then their symptoms stay up for a long period of time. And I can't tell which group of those groups you are going to fall in by looking at you. I can't tell that until we go through that together. But everybody is always an individual, and everybody has a different medical history and a different family history and different risk factors and different weights and smoking and everything else. And that's why no doctor should be giving you personalized medical advice on social media. And when we talk to our friends and we're trying to do good, let's really be clear. Some of those stereotypes about women talking are really useful, because when you get this correct information and you talk about it, that's really helpful. But I always say the plural of anecdote, the plural of my brother's sister's wife's mother took X and it made her feel better, is not the same as data. The story of the 3 friends that you know is not the same as studies that involved hundreds of thousands of women. So the fact that one person really disliked or really loved or hated or got on marvelously with one medicine does not mean that will be the same for you. And that's one of the very many reasons that, for example, we say never share your medicines. Even if you think you're on the same thing, don't share medicines. So yes, everyone is individual, and often we are, those of us in the menopause space, there sometimes is some backlash that says, oh, you're just scaring women. You're scaring them. And I say, well, actually, I've always been really clear, not everybody's going to have symptoms, and that's great. I don't think I'm scaring women. I think I'm preparing women. And if you don't have those symptoms, marvelous. But if you do, you might just remember something that you've read or recognize something that you've heard. And that might, 1, help you feel that you're not alone, and 2, help you go and get the help that you need.
Is it an ever-changing landscape with menopause of the studies that are going on that you're finding out more and more all of the time? So will the knowledge about this be constantly changing? Will women find that there's constantly new things that are developed, or like you say with herbs, and finding that this can help and that can help? Is that something that you can foresee over the next sort of 5-10 years?
So I think that there's a number of things. When it comes to studies involving herbs and natural therapies, it's actually really difficult to get the kind of data that I would be looking for. And the kind of data I'm looking for is a randomized, double-blind, controlled study. And that's actually quite difficult to get, and they cost a lot of money. And the fact that something is called natural doesn't mean it's safe. HRT comes from plants. Often the estrogen that I use tends to come from yams. It's a synthetic version of the estrogen which is found in yams. But if there is something which is working in a herb, there's something in it, right? And that something in it therefore has the potential to interact with other medicine that you're on, to interact with other health conditions that you have. So the fact that you can buy something over the counter doesn't automatically mean that it is safe. So please always talk to your doctor and pharmacist about it. I think there's a huge amount, in fact, I know that there is a huge amount of research going on. One particular area is around something called phytoserms, which are plant-based selective estrogen type molecules that act like estrogen on the bones, the brain, and the heart, but like the opposite of estrogen on the womb and on the breasts, meaning that potentially that they wouldn't increase risk of breast cancer, they wouldn't increase risk of womb cancer, though we can counteract that by using progesterone. So that's an area of research. We are definitely doing more and more research into testosterone in women. Women do have testosterone. There's and men have estrogen. And women do have testosterone, and testosterone is currently used to treat low libido in women during the perimenopause and menopause, if nothing else, if everything else has been excluded and nothing else is working. And there's a lot of research going on about the use of testosterone. And the truth is that people often complain or are concerned, why aren't the guidelines changing? Why doesn't the guidelines say whatever it is they want to say? And the answer is the guidelines are only going to change when the evidence changes, when the data shows us that the guidelines need to change. And the data will only show us something when the research is being done. And the research will only be done when we prove that there is a need for the research to be done. And that's where we are. We are right at the beginning there. We are at the bit of saying women are suffering. The economic brain drain is significant. The personal cost is significant. This is the kind of research that we need you to do. And all of that is then going to take a long time. And whilst that feels frustrating, we have to remember that we've had HRT since around the 60s. We've had the contraceptive pill since the 60s. So we've had 60 years essentially of hormone therapy. And we have to compare that to millennia of women having periods and only being judged for what they look like, their sexual attraction, and their ability to bear children. And it is going to take a long time to shift the attitudes of those millennia into where we are now and carry out more and more research into what is best and what might help everybody. I always say everyone is an individual. We are all complicated and complex and wonderful, but that is why every single person needs to go and have the conversation with their doctor and weigh up their risks versus their benefits.
I've loved listening to you. It's been an education. It really has been an education for me. I would just like to say thank you for coming on and talking about this. I've just felt like I've sat here and just listened to you, which is great. I wish you was my GP. That's the best compliment I can pay you, I think. Just it's so great listening to you. So thank you. Philippa's book obviously is out. If you're going to spend your money on anything, I would suggest that you go out and buy Philippa's book, The Science of Menopause. Because I think, as Philippa's already said, having knowledge is a great deal of power, and that gives you a place to start. And I think it's really important that we all talk about it, and for men as well in relationships to understand it, Philippa. I think that's really important as well, as you said already. But thank you for coming on to 50 Shades of Grey. Thank you for your time. I know you've been extremely busy. I really appreciate it. And thank you all for listening.
Thank you for having me.
You're welcome. I'll put all Philippa's details on here. You can follow Philippa on her Instagram, see her all the time on TV as well, and go out and get her book. And we'll see you soon. Thank you for following 50 Shades of Grey. Make sure you follow and subscribe, and we'll see you soon.